Kia ora anō e hoa mā. Welcome back to the final session of our first ever virtual annual conference. We're finishing with some familiar faces, Dr. Charlotte Chambers, Charlie, and Lyndon Keene, the mainstays of our policy and research team. I hope you're all aware already of our existing overview looking at the mental health crisis in New Zealand that we released earlier this year. Today we're releasing a longer piece of research coming out of our survey of psychiatrists conducted by Charlie and now written up and ready to launch into the universe. We're going to have a short presentation from Lyndon looking at the wider context of mental health and the issues we are facing, followed immediately by Charlie presenting her findings, and then there will be a joint question and answer session which I invite you to continue to use Slido for. You're welcome to send your questions at any point through either presentation, but we won't be having any questions in between. We'll have both presentations and then finish with a Q&A. So here we go.
Kia ora, I'm Lyndon Keene. I'm joining you from my home on the Illawarra coast, which is just south of the Royal National Park in New South Wales. This is part of the ancestral homeland of the Dawarol people who've looked after this place for many thousands of years pretty well, for which I'm hugely grateful. I'd like to acknowledge them as the traditional custodians of Dawarol country and pay my deep respect to them and their elders, past and present. This is down at the local beach when COVID restrictions were lifted. A good day for mental health. Okay, so while this session is about mental health services, the issues discussed, of course, have parallels in many other specialties. So what we're presenting here really is just an example of what's happening in other parts of the health system to one degree or another. As is often said, mental health is everyone's business. Especially every doctor's business, and for good reason. Prevalent studies indicate that 50 to 80% of New Zealanders will experience mental health distress or addiction challenges, or both, in their lifetime. And those that haven't are likely to know someone who has. Mental health patients have higher rates of many other health conditions requiring care in other parts of the health system. Doctors themselves are more likely to suffer poor mental health than other professionals. And the annual cost of mental illness in New Zealand is estimated at around $12 billion or 5% of GDP. And that's a figure from 2017, so it'll be a bit higher now. So if mental health services are not functioning well, there's a considerable flow-on effect for the rest of the health system, for the well-being of our communities, and the health of our economy. Turning now to the figures, the Mental Health and Addiction Inquiry of 2018 said, and I quote, there are some indications that prevalence appears to be increasing, end quote, which is a nice understatement, I think. This chart, using data from the New Zealand Health Survey spreadsheets, I think makes it pretty clear. Diagnosed anxiety disorder in adults more than doubled between 2011 and 2019. Depression increased by 32%, while the population increased by just 13.6%. Why is this happening? Well, there will be many reasons, I guess. There are widening wealth inequalities, for example. Unequal societies are more materially competitive, more hierarchical, and more stressful. This leads to higher rates of stress-related illness. The Mental Health Inquiry mentions the pressures of modern life, including the effects of social media, etc. A more faster culture is not necessarily a healthy one. In fact, I read recently of a place that offers speed yoga for those too busy for the traditional take your time to breathe version. And there's a US funeral home apparently that offers drive-in funerals for time-pressured mourners to quickly pay their respects to their dearly departed without having to get out of their car. So speed is becoming an addiction, it seems. Makes you think. Now, for children, unlike adults, anxiety disorder is more prevalent than depression. Though, like adults, there's the same upward trend where the prevalence for both anxiety disorder and depression is increasing well above population growth rates. The numbers have more than doubled over this 9-year period. This should be raising alarm bells, but I don't hear any. Now here we see the growth in the number of unique mental health and addiction patients seen. I'll call them MHA patients. So this is MHA patients seen by district health boards and contracted NGOs in any given year. Unique MHA patient numbers increased by more than double the population growth over this period. This appears to be levelling off in the last couple of years, as you'll see, but COVID restrictions have led to underreporting in 2019-20, and in fact the 2021 data is also incomplete. Now, before I move on, just a quick note about language, because there's a lot of what I call corporate accountancy terms creeping into the health language over the years. Supply and demand, outputs, inputs, productivity, clients. Now, I've been guilty of using some of them myself without thinking about it too much, but I'm going to make a conscious effort here to use the language of healthcare. So I'm not talking about demand, but health need. I'm not talking about clients, but patients. And by patients, I mean it's where the therapeutic relationship is a collaboration and is empowering. Okay, so moving on. Drilling down, trends in new referrals to MHA teams probably give a better picture than patient numbers alone of how workloads are increasing. Over the period here, the population grew by 16%, while new referrals to MHA teams grew by 78%. In fact, it will be higher still when the underreporting than last year is corrected. A big portion of these were self-referrals or referrals from relatives, which increased by a whopping 170% over this time. Referrals from GPs have increased by 96%, and the gap between patients seen and new referrals is largely due to multiple referrals for individuals. It indicates a revolving door effect with increased movement of patients between services. It's another sign of a system overwhelmed. Looking at the makeup of MHA patients, there's a pretty clear picture showing that the degree of deprivation and ethnicity have important bearings on mental health. Note that these are actual numbers. So you can see how Maori, who make up 17%, about 17% of the population, are disproportionately represented here, especially in quintile 5, the most deprived, where Maori are actually in the majority. Now, aside from anything else, I believe the data here provides some stark messages for what's needed in prevention and early intervention strategies. Going to the psychiatrist workforce, well, many countries are experiencing shortages in their psychiatrist workforces. New Zealand appears to be faring particularly badly. Now, the data presented here is sourced directly from the countries where possible, because I've found that OECD and WHO workforce data is often not exactly apples and apples. As with all international comparisons, however, caution is needed in interpreting the results. But on the available evidence in New Zealand, we're not doing very well on this measure. Looking at the DHB psychiatrist workforce specifically, as you'll see, there was reasonable growth between 2011 and 2015, along with the workload, of course. But lately the numbers have levelled off and even dropped slightly. When you compare this with the earlier chart of unique patients seen, let alone new referrals, the trends illustrate what the 2018 MHA inquiry called, I quote, increasing and unsustainable pressure on the current system, end quote. The inquiry also observed specialist services operating at capacity, applying restrictive criteria, and being able to accept only the most distressed or unwell people, end quote. In other words, there's a big unmet need, and of course, we know this from many reports and feedback from our members. And if anything, the feedback indicates that things are even worse now than when the inquiry completed its work. Look at nurses. The nursing workforce in mental health are faring no better than their medical colleagues, unfortunately. The total mental health nursing workforce, including all employers and nursing scopes of practice, increased by 16% between 2011 and 2019. This was less than half of the growth in the number of patients seen over that same time. The growth of the DHB-employed allied workforce has similarly fallen behind the growth in workloads. DHB social worker staffing, for example, increased by just 2% over this 9 years. Psychotherapist staff actually fell by 34%. So any idea that perhaps some members of the MHA team might be able to provide extra support to relieve their under pressure colleagues has to be discounted. All members of the team appear to be in the same boat, frantically failing to stay afloat. Looking at bed numbers, DHBs frequently exceed 100% occupancy levels for MHA inpatient beds, when 85% is considered the standard for balancing clinical safety and cost efficiency. This chart shows the average rate for each year. Now, despite this, the number of available inpatient MHA beds per population has fallen by nearly 10% in the last 5 years. The number of psychiatric beds per head of population is already amongst the lowest in the OECD. We're moving in the wrong direction, it seems. Finally, funding. Not only has the number of MHA patients grown well above population growth, but also well above the growth in funding. So the average funding per patient in real terms has decreased and decreased, in fact, by an estimated 20% between 2010 and 2019. Funding for specialist MHA services for people with the most severe needs has been set to cover 3% of the population in any given year for more than a quarter of a century, though many DHBs are having to cover more than 3% of their population. And it's not really clear how that's been funded. The best evidence available, which is now 15 years old, indicates closer to 5% of the population has a severe need. In response to the MHA inquiry's key recommendations, funding to provide more support in the community for those with mild and moderate needs was increased significantly in 2019, be it from a very low base. Although our analysis suggests that the amount of funding fell short of the intended expansion of services, and there's been some questioning of exactly how much has actually been spent. MHA specialist services, on the other hand, have had to make do with annual adjustments for population growth and inflation, despite the obvious need that much more is needed. Now, the official rationale for this is that more emphasis on improving prevention and early intervention in the community will see demand for specialist services reduce. Of course, there's no doubt that more MHA workers are needed in the community, as they are in hospitals. But as we've seen earlier, prevention policies, we need to go much deeper into addressing the determinants of poor mental health to be really effective. So I'll leave you to ponder that. And in the meantime, I'll hand you over to Charlie. We'll be talking about what all this means for the well-being of our SMOs in psychiatry. Thank you. And I do hope this hasn't depressed you. As I said earlier, we will be looking at ways that this can be fixed, these things can be fixed later on. Thank you.
Ngā mihi nui kia koutou, and thank you so much to Lyndon for setting down the scene. I'm really picking up the same mantle here, but focusing on what it's like for those who are actually working inside the front line of the mental health crisis. Now, as Lyndon has already explained, in many ways, the mental health crisis doesn't really need any further introduction. But a brief search of news headings just from the past week have brought up these quite horrific headlines. And of course, this most recent article is coupling precisely what Lyndon's been talking about, the underfunding and the under-resourcing of our mental health services, and how this actually precludes the services from seeing face-to-face the people who need the help. So we know that psychiatrists are working in a system characterised by rising demand, reduced bed capacity, and incredibly stressed and stretched services. So given this context, how is it that our psychiatrists are faring? We know, at least anecdotally, that things are not great, and I have to commend my industrial colleagues here for really doing some excellent work to assist psychiatrists, as well as all the other medical professionals around the country with dealing with the issues that they face. But we really have to understand that psychiatrists are the cornerstones of the teams responsible for the delivery of mental health services. At the end of the day, the buck stops with them. They are the ones who hold the primary responsibility underneath the Mental Health Act. And we also know that psychiatrists hold a particular risk and propensity for experiencing burnout. And this is because the patients that they have to deal with are some of the most acutely unwell in the country. And they're physically at risk of assault. They're at risk of aggression and aggressive treatment from their patients, and often at risk of violence. And furthermore, as that previous news article highlighted, they're dealing with people who may be suicidal, and the impact of losing a patient can be huge. International research also suggests that the number of people wanting to enter into psychiatry is declining. I read a paper based in the UK back from 2017, which characterised an apparent recruitment crisis in psychiatry. And they found that this was due to stigma towards psychiatry as a specialty, as well as perceptions of the levels of bureaucracy involved, as well as the poor morale from those who they were training with. And it appears that this is not a problem isolated to the UK. From a brief dip into the latest statistics from the MSOD project from the University of Otago Medical School, I found that psychiatry was ranked 8th overall out of 10 broad specialty choices. We also know that being able to deliver high quality mental health care in turn depends on having a healthy, well-supported mental health workforce. So it's crucial that we understand the impact of the quantitative measures that Lyndon's just outlined in terms of what they mean for the individuals who are at the core of our mental health services. And this is where I'm trying to insert this research and fill this gap. Now, throughout the presentation, you'll see quotes on the screen. These are taken directly from the views of the people who participated in this piece of research, and they really emphasize the individual perception and the personal cost of these broader issues that we're talking about. So the research that was designed really had these 4 core research objectives. At its base, I sought to investigate key dimensions of the psychosocial well-being of psychiatrists. And I did this by looking at a single item measure of burnout as defined by the Maslach burnout inventory, a single item measure of perceived job stress, and there were some secondary measures as well. I used the Health and Safety Executive Management Standards tool to look at perceptions of peer support, managerial support, and also workload demand. And then through various analysis, I sought to identify the main risk factors for work-related stress and burnout, as well as really gauging individual perceptions as to how workloads have changed over time. And finally, in terms of the consequences of this, I sought to assess individuals' job satisfaction and also their intentions or their plans to leave their work. So I'll touch on a few of these points today, but of course the main report has just been released and you'll be able to read it in detail on our website in due course. So in terms of the survey itself, we had a fabulous response rate. 70% of psychiatrists who are members of the ASMS responded to our survey. And I would like to take this opportunity to thank all of you who took the time to participate in this research, because it really does make a huge difference to the validity and the legitimacy of the research that we do. This slide shows the demographic profile of respondents, and I thought it was quite interesting. We have 50-50 male-female, but we also have a fairly aging medical specialty here. 65% of respondents were aged over 50. The majority, of course, were working in adult mental health. And here we see 60% of those who participated in the survey are actually international medical graduates. And this figure is consistent with that held by the Medical Council. And psychiatry is the specialty with the highest proportion of international medical graduates in New Zealand. Now, this diversity is fabulous. And interestingly, it's a trend which has been consistent over time. Nearly 20 years ago, research by New Zealand psychiatrists Snyder and Kumar found a similar proportion of IMGs, and they argued that it was really important to delve into the experiences of our international medical graduates in psychiatry in New Zealand in order to help us reduce our heavy reliance on locums, as well as to try and change the tendency for IMGs to leave New Zealand after a relatively short period of time. Now, given our particular context that we have here in New Zealand, not many of our medical students wanting to get into psychiatry, as well as problems with recruitment internationally speaking, this high reliance on international medical graduates needs to be treated with a little bit of caution. We cannot keep relying on the international medical workforce to supplement our own, given that we know competition for IMGs is likely to escalate because worldwide countries are struggling to fill their vacancies. In terms of the psychosocial wellbeing, we found that it was actually slightly over 34% reported what was scored as high levels of burnout. And this is the red bars here. It's scoring as burnt out once a week or more. And also, although it's not displayed here, almost exactly the same proportion were reporting with very high levels of job stress. Over half of the respondents scored as experiencing moderate to high levels of burnout, which is the amber line and the red. So even though burnout per se, or high burnout, is only affecting over a third, it's still not a great situation because, as I know from previous research, suffering from high levels of burnout really means you're kind of at the limit of your abilities. And the comments left for this section of the survey, as always, were very revealing, and they included reference to the various factors that were driving burnout, as well as describing strategies to mitigate against burnout, which included taking time off work, changing places of work, or decreasing hours of work, as well as moving into private in order to make their work more manageable. When I looked at the proportions of those scoring with high levels of burnout by DHB, statistically speaking, the numbers were too low to make any of these variances statistically significant. But as you can see in this graph, the variance is fairly huge, ranging from only 8% at Northland to over 60% at Waikato. Similarly, in terms of the job stress scores, there were no respondents at either Hutt Valley DHB or Taranaki who reported that they didn't find their work stressful at all. So huge amount of variance here, some DHBs which appear to have pockets of really significant issues. If you're wondering why your DHB isn't on the list, that's because there would have been fewer than 5 respondents at that particular DHB, and I didn't want to report the scores for fear of identification. In terms of the consequences of all of this, the research told us that 45%, if they were able to, would leave their current job. But it also told us that 63% of the current specialist workforce had some desire or at least sitting on the fence. And this amounts to 161 individuals who would like to leave and 66 who are sitting on the fence. That's a fairly significant number. In terms of actually having firm plans to leave their work, only 23% had firm plans. But this percentage alone equates to 77 psychiatrists, which is a number that I know we can ill afford to lose. Again, the value of the comments here is that it revealed a good level of indecision here. Some noted their desire to leave the more grueling aspects of their work or to reduce their hours, or to shift to different DHBs that had better staffing ratios. And some of the comments included things like, I'm weighing up my options. I'm either going to completely retire or I'm going to move overseas to Australia. I would like to continue mixing psychiatry and pain medicine, but I would not return to community or inpatient psychiatry. I'd like to do the same job, but in a DHB that has better staffing ratios, a greater number of SMOs, FTE per population. Now, one of the key goals of the research was to gauge perceptions as to how workload, both in terms of quantity and quality, had changed over time. Now, 2018 was the year that we chose as a reference point because this was the year that He Ara Oranga was released. And at the time, the report stated that they expected demand for specialist services to reduce as issues are dealt with earlier before they escalate. And so we reminded participants of this statement and we asked them to cast back to this time when they were working in New Zealand. And we thought that this would be a useful touch point because at least the report claimed that demand would be reducing over that 3-year period. Perhaps unsurprisingly, this statement was met with frustration and at times incredulity. One person responded that, I despair when I read that statement because it bears no resemblance at all to reality. And when we look at the actual responses, the red here, of course, tells or paints a fairly significant picture. What I take from this is a near consensus regarding increases to the acuity and the demands of workloads over the past 3 years. There were no people who felt that the complexity of their caseload had either decreased or significantly decreased, and 95% felt that the demand for their services had either increased or significantly increased over the 3-year period. It's a fairly significant indictment on the mental health service. Some people noted, and I quote, I have worked for this DHB for 20 years. The amount of people that we see, the complexity, it inexorably rises and it gets harder and harder. I still think that psychiatry is a good job, but most of my senior registrars arrive at our team saying they don't want to be psychiatrists, as all the psychiatrist jobs look awful. It's very sad. When I look back on patient files, I'm reminded how much care we could provide 5, 10, and 15 years ago for specific patients compared to now. Another noted that their on-call shifts have become almost universally busy with increased referrals, acuity, and complexity. And in addition, inadequate resources can mean a disproportionate amount of time is spent in resource discussions rather than clinical care. And another person noted that they felt the demand was due to an explosion of methamphetamine and drug-related mental health problems, escalating family violence and child protection issues. Now, while the survey did not attend explicitly to the issue of recruitment and interest in psychiatry, there were a number of comments which referenced issues with consultants working without junior staff, as well as in that previous comment, noting the reluctance of registrars to get into psychiatry as their specialty. And this person, of course, notes that junior staff are missing, and as a consequence of that, the consultants are the ones doing the data entry and the phone calls. And this trend seems to expand without any additional resources. Another comment noted that I am called upon to conduct tasks that can be done by junior doctors, registrars, and house officers. In addition to what I'm supposed to do as a consultant, I am swamped with paperwork. The Mental Health Act is an extremely time-consuming process. Therefore, I'm unable to use my time effectively to provide a specialist level of care for my patients and their whānau. The other subjective indicators of demand included in this research were questions pertaining to perceptions of time with patients to provide a preferred level of patient-centred care, and whether participants felt their service was resourced appropriately, as well as how frequently they covered the caseloads of their colleagues. So here, under a third agreed or strongly agreed that they had sufficient time to spend with their patients to deliver patient-centred care. And in the next graph here, only 11% reported that they rarely or never covered the caseloads of their colleagues. 41% said that they were always or usually covering the caseloads of their colleagues. And comments in this section included things like, we now see lots of patients who come straight from prison. Forensic services are overwhelmed, and they have usually been significantly traumatized in prison. I've discharged numerous patients as soon as they achieve some tenuous stability, but new ones keep pouring in, and most of my patients are also poor. Another person noted, I'm referred more complex patients, but with fewer resources and too little time. And I think here, this really suggests that we need to have some really rigorous longitudinal research to track these indicators of demand and how it's impacting on the level of care that clinicians are able to provide. And again, as already heralded, respondents overwhelmingly disagreed that they were provided with sufficient administrative support, as well as 87% disagreeing or strongly disagreeing that they're working in a well-resourced mental health service. I think the issue of admin support is a really interesting one. People use this question to reference broader issues such as poor IT services and general frustration with not having enough resourcing. And comments were great, well, really depressing, but very useful. One person noted that there is no admin support. When I was a registrar, I used to have admin staff who would type letters, but now all of this is done in one go. I see patients and their whānau, I organise follow-ups and scripts and type letters, and I send out reports all in the same time frame. But luckily, there is still the joy of working with the patients. And it's this tension, I guess, between the pressure of the workloads versus the satisfaction that the clinicians still get from working with their patients. And that's what I've tried to indicate in the title of this research. Another person noted that their caseload is 150 plus patients, which is well above the average for other parts of the service. I highlight these concerns regularly, but additional resources not forthcoming. I submitted data for service sizing over 2 years ago. I'm yet to receive a response from management. I also conducted an odds ratio analysis in this work, and I found that respondents who reported good levels of admin support were 28% less likely to find their job stressful, and they were 37% less likely to score with burnout. So again, we can start to see what relatively simple changes may make a fairly significant change to the working lives of the psychiatrists. Non-clinical time was a bit of a doozy. Well over half reported that they rarely or never access their non-clinical time. Only 56 individuals felt that they were always or usually able to get non-clinical time. And non-clinical time was variously described as a joke, or the time when the clinicians would catch up with their clinical admin tasks. And others noted that management look down on us if we even talk about non-clinical time. It's considered taboo, as if the Mecca has not been read by the management. Again, and this was backed up by the odds ratio analysis in this research, International literature suggests that regular access to as little as 2 hours a week of non-clinical time is likely to reduce the likelihood of experiencing burnout. Now, we already recommend 30% non-clinical time in the MECA, but again, along with the findings around putting in place admin support, you can see here how relatively simple things like ensuring access to non-clinical time could significantly change the situation for the psychiatrists in this study. But of course, this can only happen if resourcing and staffing is better matched to the demand for mental health services. Now, despite all of this, the psychiatrists reported relatively high levels of job satisfaction. Just under 50% reported being either satisfied or very satisfied with their work. Now, this is actually not unusual, and it's a trend that I've seen in all the research that I've done to date for ASMS. Doctors continue to place a huge amount of their own personal fulfillment and satisfaction in their work with patients. And this value that they place on their patient interactions continues to be a source of their professional and personal fulfillment. And comments again in this section noted that it's the interactions with patients that keep me focused and enjoying my work. Now, the persistence of this relatively high job satisfaction is really heartening. But I think here, and reflected in these quotes, this job satisfaction we cannot take it for a given, and we can't continue to run our mental health services on the assumption that only 3% of the population require this level of care. You can see here the frustrations that people are speaking. I don't like feeling I could do better. I'm a little bit ambivalent about my job. It has a huge impact on my private life. So what to next? What specific things can we do to start making a change? Well, within all of this, this research was conducted in May of this year. And of course, this was just before the main wave of Delta hit New Zealand. So we know that COVID-19 is going to continue to have a significant impact on the well-being of all of our health workforce. But also it's likely that demand for mental health services is going to escalate as the pressures on our health system continue to grow. We're also in the middle of a review of the Mental Health Act, and this may institute changes to the working requirements and the demands on psychiatrists. And I think it's going to be incredibly important that we continue to monitor the impact of these issues very closely. So again, in line with the work that Lyndon's already pointed out, we can see here both the statistics back it up, the research in terms of the perception of the clinicians back it up. Workload has grown exponentially. We know that we're dealing with this exponential growth in workloads, the demands of call, as well as the patient complexity levels. And I think, again, with Lyndon's work, this really emphasises the need to do some kind of a workforce census. We have to start thinking, and hopefully this research will be treated as a clarion call for those who are responsible for workforce planning in psychiatry. So we need to have this urgent workforce census. We also need to have this reallocation of resources into mental health to enable sustainable workloads. But here I've highlighted it in red in terms of the really nitty-gritty, pointy stuff that my industrial colleagues are busy working at. We really need to emphasise the need for this service sizing work. At the moment, I think it's incredibly clear that demand is not aligned with the number of psychiatrists able to provide care. And if we had updated service sizes, this would perhaps start actually accounting for this growth in demand and laying down the foundations for greater staffing. Similarly, of course, we also want to see all mental health providers being urgently job-sized. And this is to ensure that psychiatry workloads are safe and sustainable. There were more than one comment in this research left by people who said that after their on-call shifts, they were actually taking annual leave in order to get their adequate recovery time. That's just not acceptable. The work cannot be that unsustainable that people are having to use their own leave entitlements in order to make it safe. So we have to ensure that every psychiatrist has a clearly defined workload, which accounts accurately for the growth in demand and the patient acuity that we're seeing in this work. And this is fundamental to achieving safe work. I think this research also lays down a fairly strong challenge for our new national health employer, Health New Zealand. Another issue that I haven't even touched on is the impact of having buildings and infrastructure that are not fit for purpose. And here, of course, we can see the issues down at Hillwalton. But the comments in this report do talk about that and the impact of poor physical work environments, the consequences of having non-functional IT systems, and also the sheer challenge of getting simple things done, like booking cars, for example, and the logistical challenges involved in just doing the basics of their job. None of this is going to improve doctor well-being, and it's also not going to improve the quality of the health outcomes for our mental health patients. Again, the fact that psychiatrists continue to have relatively high job satisfaction is a really great thing, but we can't keep riding on that. We have to understand that job satisfaction and goodwill is going to dwindle if changes are not made soon. We cannot keep running our forensic, our inpatient, and our community-based mental health services on this assumption that only 3% of our population requires their care. We have to make sure that funding is increased to better account for the demand, because at the end of the day, the health of both the patients, but also those providing that care, depends on it. So I'm going to now hand back to Lyndon, who is going to talk about some specific things that we want to do in order to ensure that these changes are made. Thank you very much for your time.
Thank you, Charlie and Lyndon. Lyndon, are you there?
Lyndon, unmute yourself.
Right, forgot to unmute. Can you hear me now?
We can, Lyndon, thank you. Do you want to make a couple of comments, or do you want me to hit the questions and comments straight away?
Well, I did say we'd go through some solutions. So I'm conscious of the time, so I'll go through these very, very quickly. I think Charlie has, okay, let's just put them all up, Charlie, shall we? And I'll go through these very quickly. So there's funding is an obvious one. As we all know, the mental health and addiction specialist services have been funded to cover 3% of the population in any 1 year. That cap really was set in 1994, would you believe? And it wasn't even based on New Zealand data, but data from New South Wales. Ever since then, there have been various opportunities to review that, but it simply hasn't happened. In 2006, there was a comprehensive survey done of prevalence of mental ill health in New Zealand, which indicated that close to 5% had a severe need and therefore needing specialist services, but no action was taken on that. You get to the mental health inquiry in 2018. Again, they acknowledge that maybe 5% is a more realistic cap, but they didn't recommend an increase. Consequently, of course, the government in its budget after the inquiry in 2019 didn't increase specialist services. So we've all along had to go, specialist services have all along had to go along with just adjustments for inflation and population growth, stuck on that 3% coverage. So we're saying that we urgently need to go, for funding to be lifted to cover 5% of the population based on that data that's now 15 years old as a stopgap until we get more up-to-date information, which is what the mental health inquiry recommended, but which the government only accepted in principle, and it's really not clear what they're going to do about that. So we obviously need a comprehensive data on mental health need, so the prevalence by severity, by ethnicity, by deprivation level, and so on. Then we need a we need. I'd say I think for that 5% actually is probably very conservative because. Well, as I say, it's 15 years old. We know from other data that prevalence has seemed to increase quite considerably. One recent study suggested it might be as high as 9%. Severe need might be as high as 9% of the population. In Australia, New South Wales, they're indicating that probably around about 7.5% of the population will need access to a psychiatrist in any 1 year. So you can see we're way behind. So once you've got the information on the need, then we do what Charlie just mentioned, the stock take of the workforce. We need a workforce census. You just got to understand where we are. So then you can put together a workforce plan, which is basically aimed at aligning the need or aligning the workforce with the need. I mean, it's not rocket science really, it's just a logical thing to do, but somehow that's eluded us for so long. So we need to know the need, we need to know what workforce we've got, and then we align the need to the workforce. And it's an integrated workforce, obviously there's huge shortages across the whole spectrum of mental health care. We know about psychiatrists, huge shortages. I read recently that clinical psychologists need about 1,000 more workers. That was based on a 2017 analysis. So right across the board, we're just really struggling. Then a workforce plan would also need to be regularly updated with comprehensive surveys of need and be supported by the kind of research that we've seen this afternoon, like the excellent research done by Charlie and in the previous presentation on general surgery trainees. And as has been commented, the issues that have been raised are not just in these specialties; they go right across the board. So we need that to happen. We need there needs to be a comprehensive all of government strategy with resources to address the determinants of mental ill health. The mental health inquiry recommended a standalone social wellbeing agency at central government to coordinate all this because it found that this wasn't being done, which is no news to anyone. We actually go further and would suggest it actually needs a senior minister in cabinet to be heading this as well. Finally, a campaign, because we've been talking about these things for so long. When you look at the mental health inquiry of 2019, that didn't come out of thin air. It came out of years of intense campaigning by community groups and by health sector groups before the politicians realised that they really needed to address that. Of course, the inquiry, the specialist services turned out to be a big blind spot in the inquiry. So there's a lot of unfinished business to be done. And we really does need to be a campaign now to put pressure on the politicians to accept that actually there was a big issue that wasn't dealt with in the inquiry, and that needs to be done now, and that is addressing the under-resourcing of mental health specialist services. Thank you. I think.
Thanks, Lyndon. I'm just going to flick through the next slides. We've already talked about it. Establishing minimum safe staffing levels, amongst other things. Also a focus on IMGs. This is something that is not new, but it is something on the books for next year. And just finally, in terms of the campaign work we're doing, if you are a psychiatrist, hopefully you've received this direct. We are going to be running meetings, kick-starting on the 10th of December, where we are going to be combining as an industrial and a research team to talk you through some of the nitty-gritty of what can be done about it. So I'll pass over to Sarah now, who's going to run through some of the questions.
Thank you both for putting that presentation together and helpfully, my Slido's just completely disconnected. Aha, it's back. Alison Stern says, hi, very interesting statistics, thank you. Do you have a breakdown for adult age 65 and over presenting to mental health for older persons services? I think this is important as the older population is exponentially rising.
Not on hand, but I'll have a look at that and come back to you.
Another question here talking about the impact of COVID. So Tindra notes it has caused a further increase in mental disorders. With increasing demand and psychiatrist shortage, it is hard to take leave since there is a limited cover available. Yes, I think that's precisely the point that we need to keep in mind. The problems outlined in this research are likely to worsen over the near future. So thank you for that comment.
Okay, so Mark Fantaviva, Mark, you've talked about this before, I know at JCCs, about this shortage of psychologists, and I know that we've just noted that in the presentation. So at Whanganui DHB, there's a severe shortage of psychologists and an apparent inability to recruit more, which leads to our personality disordered clients not receiving any psychological therapy. This results in increased deliberate self-harm. How can we attract more psychologists to work in our DHBs?
I'd love to know the answer to that. We are collaborating with I think they're the Association of Clinical Psychologists on this work as well. They're aware of it. So we're trying to take a more joined up approach to some of these issues as well, not just focusing on the psychiatrists.
Did you want to comment at all on that, Lyndon, or are you happy for us to move on?
I think there's a petition. I think it was the College of Clinical Psychologists who presented a petition to Parliament very recently about the issues they're facing, severe shortages across the country.
I think they have real issues around terms and conditions, salaries as well, which, is no surprise, I guess, given the pressures that we face as well. Suman says, thanks, Lyndon, for an excellent presentation. While funding for preventive services is a good move, without concurrent increases in specialist services, the resultant increase in demand is overwhelming the specialist services and affecting care, and this needs to be rectified. And I'm sure you'd agree that we're calling for yes and approaches to funding and support for mental health interventions at every level.
Definitely. I mean, Lyndon is really the brains in this regard in terms of the funding statistics, but we're not wanting to take away from the funding that's really importantly being directed towards the mild to moderate needs, but we have to increase the amount that is ring-fenced for those who have the severe need in our country. And the fact that the 3% is such a spurious figure and was dated back to 1994 is just ridiculous. Lyndon, I'm sure you want to chip in here.
Yeah, well, the government is stuck on this idea of, a very simplistic idea really, of putting more money into the community, in mental health community services. Of course, they need more money, of course, so it's good. Are you there? Because I've lost you.
Yep.
Are you, yeah?
Yep, we're here.
Okay. So that's good because it's needed, but it's a very simplistic idea that's not really supported by evidence that shows that if you shift, if that's all you do, then everything will work out and specialist services will reduce. Well, you've got to, first of all, you've got to ensure that there are sufficient resources going into the community to do it, and we're a long way away from that at the moment. I mean, this is years and years away before we get there. And then, of course, you've got to address the determinants of health at the same time. And again, that's the long-term thing. So, it seems they have this almost ideological idea that if you just kind of shift from one to the other, it will all work out, instead of what they should be doing, which is looking at a holistic, whole of government approach to this, where you have integrated services, integration between community and secondary care, because of course one depends on the other anyway. If one's not functioning properly, the other one won't be. So, you've got to do both of them, not just one or the other. It's not either or.
Thanks, Lyndon. Jeff Shaw says these are consequences of failed health economics and will only get worse unless there is new thinking. Looking at health deficits in the same way as budget deficits through a modern monetary theory MMT lens balances investment with need. Should ASMS engage an MMT economist to inform this debate? Do either of you want to comment on that?
I think there does need to be a big public debate on health funding, because we need a quantum leap in funding. I mean, it's no good doing what we've been doing for years, or even now, where we've had, at least the real funding cuts have stopped. So, but we need to have a quantum leap in funding, really, and that requires a big shift in attitudes from the politicians about how they fund health, and that needs a debate. Treasury at the moment, I mean, there was a document from Treasury early on in the year saying current health spending is unsustainable. Well, they've been saying that for decades, but they get listened to, and there isn't a kind of balanced debate on what happens if you don't fund health properly, and what are the benefits of actually having a good health system that functions properly. What are the benefits down the track? So there is a real debate that's needed, and it'd be great to get some economists involved in that. Absolutely.
Thank you. Satindra says, thanks for the valuable research work. These issues have been known for long but conveniently ignored. Joe Lane, thank you both for your mahi, much appreciated. David Goldsmith comments that the last service sizing at his DHB was in 2012 for one of the fastest growing populations in the country. We're very aware of this, and we do encourage you to reach out to your industrial officer. We are available to support you, and we know a number of our industrial team continue to work with services. A number of you are very embattled. We do understand that, but we are there with you, and we will continue to do that. And I do encourage you to attend the Zoom meetings that we've organised for December. Suresh asks if there's any move towards making primary care, GP care free of charge to reduce the barrier to discharge from specialist services. We ask the very same questions in the Creating Solutions publication, in our Health Matters publication. We asked the Minister this morning. We will continue to push the government on these things. I also note that the Council of Trade Unions has adopted this as a policy position since we raised it at the Women's Conference and then at their biennial conference this year. So we continue to work hard on that important matter. Paul Wilson says these problems were clear and present in Justice Ken Mason's report on psychiatric services in 1988. Yes, we take your point, Paul, it is gloomy. Carol Chan comments, it is important to support and manage children and young people with mental health needs. In many regions, psychology and psychiatry services in both primary and secondary services are woefully inadequate. This has flow-on effects to other aspects of need for the rest of the lifespan. We completely agree, and we very much see the intersection of these different services and the negative impacts they have on people's well-being and overall health and life expectancies. And I think we'll leave the final comment to Mark Lawrence. Kia ora, Mark. He says, tēnā kōrua ki te mahi nei. Thanks for humanising the clinical reality and challenges within psychiatry. Some regions have full training posts for trainees who have appropriate protections for their work conditions. I will share with the board of the college to consider your recommendations. Tino pai. I think that's a great note for us to conclude on. And other than thanking Charlie and Lyndon for the fantastic work you continue to do for the association, for our members, the quality of that research, and also the quality of the political advocacy and engagement that sits alongside that, I now ask our President, Julian Vyas, to close the conference for us.
Thank you, Sarah. So it falls to me to bring the conference to a close, and first of all I'd like to thank VidCom and the Intercontinental Hotel staff for their support and expertise throughout the day. Sarah and the National Office teams, all the National Office teams, have again done us proud with the care and attention to detail that they have shown to the conference, as with everything else they do. And again, I'm very grateful for that. I'd like to acknowledge the support that I have had in the last few months from Andrew and Natalie, who I regularly bother for their thoughts and advice, and from the wider executive, who are the backbone of our governance and leadership responsibilities. Again, thank you. Lastly, thank you to everyone out there for tuning in and joining in with Slido and the polling. A union is its members, and so your contributions are vital to ASMS for today and for going forward. It's customary at this point to wish you all a safe journey from the conference. So in your travels, from your workrooms or studies, probably to the kitchen and the kettle, I will wish you haere tu atu, hoki tu mai. Go well and return in good health. Thank you, everybody. Cheerio.